Before we jump into the episode, I want to thank our newest How I Doctor sponsor, Savaro. Savaro is a top telestroke and neurology company that was built to fix one of the most predictable failures in modern medicine, getting timely, consistent access to a neurologist when you actually need one. Their team of board-certified neurologists deliver rapid video response, clear decision-making support, and continuity from the first exam all the way through treatment planning and management. Hospitals working with Savaro see faster door-to-needle times, fewer transfers, and measurable improvements in patient outcomes. And because Savaro was built by physicians, the workflows actually match real-world medicine. If you need stronger, faster, and more predictable neurology coverage, visit savaro.com to learn more. And now, let's get into today's episode.
I think we have a responsibility to take stock, both at the NCQA and more broadly, and say, are we measuring what matters? Are we making it useful and actionable and consistent for people? And is the healthcare system moving towards more of a system that can deliver on those things consistently and systematically? To me, that's a very worthy goal to work towards and to try to support patients and clinicians around.
Welcome to How I Doctor, where we're bringing joy back to medicine. Somewhere in Washington, D.C., there's an organization that helps decide what quality means in American healthcare. They create the measures your health plan reports. They accredit the insurance companies. When someone says a hospital or a health plan is high quality, chances are they're using definitions that trace back to this one nonprofit. That organization is the NCQA, the National Committee for Quality Assurance. And my guest today, Dr. Vivek Garg, internist and primary care physician, just became its president and CEO, and only the second leader in its 36-year history. Vivek himself has had a pretty interesting career. Most recently, he was the chief medical officer at Humana's CenterWell, overseeing primary care for about 300,000 seniors. I'm so excited to talk with him today because I've personally had beef with the quality metrics in the past, because sometimes they naturally conflict with my goals as a physician trying to treat one patient at a time. We measure so much in healthcare: quality metrics, performance scores, star ratings, and yet the system's still not perfect. It's still broken, some would say. So today we're going to talk about what's working and what isn't, whether digital measurement can reduce the documentation burden or just shift it somewhere else, and how you write AI governance standards when the technology reinvents itself every 6 months. Dr. Vivek Garg, welcome to How I Doctor.
Graham, thank you so much. It's great to be here.
Maybe I'll kick it off really simply with a really broad question that you're probably going to be asked a million times in your career. Do you think we have a quality healthcare system in the United States?
Ooh, okay.
I'm going right for it.
You're going for it, Graham. I'd say, I don't think anybody intends not to have a high quality system with outcomes. The reality is we have it in pockets in a way that's not consistent. And so it's sort of this opportunistic thing that happens and can happen. We have amazing innovation in medical care and healthcare. People come to the US for advanced therapies. We've innovated. We've created a lot of the drugs, the procedures, the frameworks that really have shaped what modern medicine is and what it can be. We don't deliver on the basics consistently, systematically, and we all know it. And you can see it in the health of the population, which, continues to get worse in some ways, even though there's highlights of improvement. So the reality is we have, as others have said, a system that's not really a system yet. And that's a big part of why I think what the NCQA does is really important, because a lot of the things that Peggy and the team have created over the last 35 years are really critical parts of the infrastructure of quality in healthcare, alignment of standards for health plans and medical groups, the measures, as you noted. And so I think we have a responsibility to take stock, both at the NCQA and more broadly, and say, are we measuring what matters? Are we making it useful and actionable and consistent for people? And is the healthcare system moving towards more of a system that can deliver on those things consistently? To me, that's a very worthy goal to work towards and to try to support patients and clinicians around.
I want to hone in on one word you said: pockets. I honestly don't know all of the details of this space. When you say pockets, is that pockets geographically where there's less quality and more? What does pockets actually mean?
Yeah, Every graph or map I've ever seen of someone's notion of quality and costs and experience, it's a heat map with every extreme represented. Obviously, I think things do break down geographically based on community health, social supports and services, the underlying population's needs, the history of the place and the people there, and then the system that's available to them and the resources that are available to them. And so geography is I think a true line through the variation that exists in healthcare. Um, in some ways, people say geography is destiny. If you don't have access to great comprehensive primary care, if you don't have the most advanced specialist and procedural care available, if you don't have the coverage in your area because there's not large employers that make good margins that you have a job at that provide high quality commercial insurance, there's not really a possibility to get consistently optimal care and therefore have the outcomes that we know are possible in other pockets. Um, and so, you see these pockets of excellence. We've seen them in primary care. We see them sometimes in specialty care in hospitals, but we don't have a uniform framework for looking for that. So you get these large scale retrospective studies, you get inferred data based on observations or large data sets. And then everybody who's doing the work works within the realities of what you were describing before, which is they have metrics in front of them, some of which make sense to them. And so we've got to get to a place where we can look at things systematically so we can drive the system towards improvement on them.
When I say the word quality to myself, it's kind of a I know it when I see it thing. Like, I feel like if when in the moment I can be like, oh yeah, that was a really high quality encounter. That was a really low in quality encounter. But you guys actually have to define it. Does the NCQA have an actual definition for what does quality even mean?
We have a definition. We have areas that we focus in that we think are part of the picture. You could look at our accreditation programs for health plans or primary care practices and say those standards embody some notion of what a high quality operation, a high quality practice should look like to impact quality of care and quality of health. And then we have measures. We have measures about disease management, prevention, and screening, utilization, like risk adjusted ER visit rates for populations. Um, and so we have domains of things. I think the ecosystem is lacking a lot about what patients really feel like is high quality care. So that gets kind of bundled into patient experience and net promoter score. And now there's been more of a movement towards patient reported outcomes like I had my hip replaced, is my mobility to where I was told I could expect it to get. It's not that that's difficult to measure, it's that it's an added burden to survey patients. So, those concepts are important, but have some caveats. And then I think there's something to distill more about what clinicians really believe is high quality care. And I think we have to be cautious to not suppress that. But there's something to the fact that if the person treating you feels like they're delivering higher quality care as a result of something, we should probably listen to that because there's so many other things that we want clinicians to do for us and they do, but we're not measuring it. It's not resourced. They're kind of know it when they see it or do it because they think it matters. Another one that falls into this bucket in my mind is specialist coordination. There's a way to think of specialist coordination as, well, the faxes got exchanged and the notes showed up in the system, right? Like that's a little bit of what, the ecosystem measures right now. Real specialist coordination is you see a patient in the ER, you see that they have a cardiologist, you text that person or call that person, and you're like, hey, I saw your visits and diagnostics. Here's what I'm dealing with. Are you going to see this patient tomorrow? Or do you recommend a stress test now? That's real clinical engagement of specialists. And maybe we can measure that, maybe not, but it's still really important.
Dr. Garg, you mentioned Peggy O'Kane, the founder and longtime leader of NCQA. You're about to move in, or I guess you just moved in to Peggy's house. What's the first thing you renovate, and what's one thing that you will probably never touch?
The house that Peggy built is an awesome house. As I've gotten to know Peggy, she is a force of nature. She was really a catalyst at a moment when employers were becoming more active around quality. The movement towards managed care was happening, and there was nothing. There were not these quality standard programs for anyone, and there wasn't a universal measurement system. The organization has been doing tremendous work that's very innovative, and we haven't really declared yet to the world where we're going to go. And so, obviously, as a new person, that's an opportunity about where should there be quality measures or not?
Yep.
How does that tie to real individual and population health outcomes? Let's bring together a view and a roadmap around that and gather input and adapt it as we find more partners to work with on it.
Can you walk me through like how an idea becomes a metric for NCQA? Like it's probably like 1970s how a bill becomes law, little animated civics cartoon. I honestly do not know. I know there's lots of steps and input from lots of stakeholders involved, but I actually don't know how something goes from like, maybe we should do that to, oh, okay, in the next, whatever, in the 2026 version of NCQA, there's going to be a new thing like on ED boarding or something like that.
I won't try to sing that cartoon song, but I remember it well. And actually, ED boarding could be like a great example of something that ER staff and clinicians and patients care about.
Yeah.
We're not measuring it systematically as a healthcare ecosystem. It definitely impacts quality. I'm sure there's lots of studies about that, but we probably need to understand it better and do more things to alleviate it, which are hard things, I imagine. Essentially, there are these different groups and policymakers, professional societies, thought leaders who publish papers who call attention to areas where quality is not well understood or is known to be poor, or the evidence is emerging that it's poor. Usually what happens then is that somebody will create an opportunity for one of these quality measurement bodies to essentially they'll commission their work and say, we'd like you to investigate this area and look at how could the ecosystem better assess quality and outcomes here. We just received a grant in the last few months from West Health, which has a very big focus on behavioral health, and they're essentially commissioning the NCQA to look at quality measurement in behavioral health across different conditions and levels of severity, and also the integration of behavioral health into primary care. So we'll take that and do research. We'll look at the evidence. We have a very smart scientific staff that will do that. They'll engage different groups that have informed perspectives on the space, and they'll go through a process to say, are there existing measures or do you need to develop new ones? And if which ones would make sense to develop? Then there's a lot of technical and review work. So a prototype of a measure, you have to deploy it in test data. You have to spec it. Who's eligible to be assessed for this quality dimension? What's the signal you're looking for, the numerator? Can you actually produce that feasibly from the data that exists? Can you get true signals out of it? So what's the statistical rigor and yield? And so we go through a formal process once there's proposed measures that where those things are tested, the results are shared. We have a advisory group called the Clinical Performance Measurement Committee, which is an independent group of non-employed, they're advisors and people who have volunteered and been selected to be on this committee. Many of them are clinicians. They represent wide range of groups, and they independently review measures under development. And this is a 1 or 2 year cycle, you can imagine. So there's also the flip side of the rigor, which is the speed. But because the consequences, like you noted, are significant, it increases the visibility of a measure. Sometimes it gets adopted by other actors as in required reporting frameworks. So we want to be deliberate and rigorous. I think the question is, where do we need measures? What are those outcomes-focused areas that matter? How many make sense? So we could have an encyclopedia of 1,000 measures. You and I know you can't have a doctor or patient care about 1,000 measures at once. We also have an opportunity to not just create the measure compendium, but also bring together cohesion around bundles of things for specific populations or parts of the healthcare ecosystem that collectively give you a real signal about the quality and outcomes of what's happening.
Thank you so much for choosing to listen and subscribe to this show. I started off call because I was tired of flying blind as a physician, and it brings me so much joy to know just how many of you are out there who feel the exact same way. The feedback we've received, the community we're building together, it's nothing short of incredible. I want you to know that I'll do everything in my power to continue to bring you incredible conversations that put clinicians back at the center and help to change the culture of medicine. If I have one favor to ask today, it's simply this. Please, please, please sign up for offcall.com and subscribe to our podcast. Both are completely free. And roughly 38% of the people who listen to the show frequently don't subscribe. So if you're one of those people, subscribe and come join our community. I promise not to let you down. Every single subscriber allows us to make this show bigger and better and to build a stronger collective voice that'll help us make change in medicine. And to everyone who's already joined and subscribed, a huge thank you. I want to take a moment to thank our sponsor, Savaro. If you've ever waited and waited for a neurologist to call you back, you know the problem that Savaro was built to fix. Savaro is a physician-led telestroke and neurology company that delivers rapid virtual neurology coverage that's reliable. Their board-certified neurologists connect by video in under 45 seconds, and they stay with you through the entire decision-making journey. Hospitals working with Savaro report faster door-to-needle times, fewer unnecessary transfers, and measurable improvements in patient outcomes. If your hospital needs stronger, faster, more consistent neurology coverage, visit Savaro.com to learn more. Yeah, it's really interesting. I think the way it trickles down to the frontline clinician is, oh, there's this new thing that you have to do now. Sometimes that's little work and it's like, oh, this is an annoyance. Sometimes there is, like I said earlier, like a real friction with like, well, I don't think that's the right thing to do for my patient, but you're going to get dinged. Like that's the favorite medical term. You're going to get dinged by the quality people if you don't do it. So just do it. I'm sure that that's not the intent of the NCQA, but that's sometimes how I think some physicians feel about it. I'm curious how you think about Goodhart's law or Goodhart's adage, like when a measure becomes a target, it ceases to be a good measure. Like, it's almost like a Schrodinger's cat of measuring things. You stop being able to do it because humans start to behave differently because they know they're being measured too.
There's a lot of important psychology about what data and measurement and then incentives tied to them, how to change all these things, like you're citing, Graham. I think we need to be mindful of that. And right now, everything looks like a nail to the hammer. So I think reality you described is very accurate, that they come onto a report and there's some element of being judged and dinged based on them, often in a bonus program or, your reputation and the data that gets benchmarked and shared. One of my first jobs at One Medical was to create our quality framework. And so we went through a process of bringing more experienced peers together in guideline development committees to say, how do we want to treat breast cancer screening? How do we manage diabetes? And you and I know you want to get to a certain baseline and then allow for individual clinician and patient scenarios, but you don't have a system unless there's some kind of standards and insights emerge. And I remember getting data and doing chart reviews to look at where we were in hypertension management. And I went to one of my colleagues in New York and showed her data. And it did not look good, but she would call the doctors I would call for a second opinions or care. And she said, I'm going to show you, Vivek, why I will always look bad on this measure. She took me to the computer. She showed me her chart. She said, see this box for structured fields for the systolic and diastolic BP. I don't like it. I'm never going to use it. I just And then I said, well,
Yeah.
I can't solve that problem for you. But so, yeah, there's all these things. I think people feel like, A, do these things really matter? Do they matter clinically for my patients? You get 80% there if they really clinically matter, because it's hard for us to look away from those things
Yes, I totally agree.
because we care a lot. Then you get to, well, is this data accurate? And there are a lot of problems with that in the world right now. You could have a diabetes or blood pressure measure that's only built off of your EMR data. We still live in a world where it's almost impossible to have the full comprehensive clinical information view of your patient. And then it's also very lagged, which is the worst thing for practicing clinicians because we're in front of the patient, we're about to be in front of the patient, and you have things you need to get done. And then the third thing is, can I really act on this? Do I have the support, the resourcing? Is this really my thing to act on? And I think that's why right now a lot of measures are focused on general medicine and primary care or in very specific lanes. And we have to find a way to bridge what the system or lack thereof needs to do because most outcomes are combined functions of things that multiple actors do, including the patient. I don't think everything has to have a financial incentive tied to it, and we've probably overused that part of the toolkit as a system. But what I love ER docs and specialists to have a list of insights that they think matter for
Sure.
excellent care that's accurate and timely and produced digitally. Yes. And the things that they think really correlate with impact on outcomes. And then let's show them.
Yeah.
Let's show them what actually leads to the outcomes and let them say which things make sense or not.
I completely agree with you on the idea of transparency or just around what your numbers look like, and you can say, oh yeah, the data is bad, and that's one explanation. And I've found it to be really helpful to just see where I am personally, my own practice with my patients, in terms of like I don't know, number of CAT scans ordered per 100 people or something like that. In the same way that our nocturnists order way more CAT scans, well, there's not ultrasound at night. That you can't get an X-ray read overnight. And so there are a lot of explanations that make sense as to why the nocturnists are outliers, but it's also been, I think, helpful personally to see, oh, I'm middle of the pack. I'm going to keep doing what I'm doing versus like, whoa, I'm like ordering, whatever, twice as many as the average person. It will maybe kind of recalibrate or maybe question, oh, I seem to order a lot of head CTs, right? Or I seem to consult a lot. Or like, I think there are transparent ways of giving physicians feedback. Marty McCary was doing this, I think, with his nonprofit before he became the FDA commissioner, that are helpful in helping a physician, I don't know, not regress toward the mean, but like head toward maybe a number that's a little bit more in line with their peers because they frankly just don't even know that they're practicing differently because medicine is so kind of isolated in my patients, my practice, and I don't really know what other people are up to. I'm curious what your vision is about how AI plays a role, or maybe if it even plays a role in quality metric reporting or quality metric understanding. Do you have a sense for where you would like the NCQA or member organizations or payers or health systems to go or when it comes to AI and quality metric evaluation or reporting?
Yeah, it's a great and complex topic for everybody. We have so far shied away from saying we should be another group that creates another set of standards just about AI governance and deployment. There's a lot of good technology leadership and standards thinking already happening there, and getting involved in things like model drift and bias. And there's enough people thinking about that. We need to learn from them. Where we're focusing is how is AI deployed in clinical use cases and workflows that impact quality and outcomes, and taking more of a posture of discovery from the people doing those things and learning about them, maybe best practice, convening and sharing, and then finding alignment points that might be things that people over time say, hey, this should be a standard or there should be an insight here. So there's one part, which is how is AI affecting health plans in their clinical functions and quality of operations and care? Same thing with medical groups and practices. And then obviously what people as patients are doing themselves. There's also this realm of what could it unlock in terms of real insights that matter for patients and clinicians? And the one that sticks in my mind, using the ambient scribe tools like Abridge and others, is, well, we've never had a record of the conversation between the patient and their clinician before. You and I know if you sit with another clinician caring for a patient, there's a fair amount that you can assess from that.
Yeah.
Uh, the quality of their conversation and shared decision making with the patient, the patient's self-expression of their understanding of the scenario and acceptance of risk or intentionality of choice they're making. There's just so many other factors that might be more in like if we think about like the circles before of what do patients really care about and what do clinicians really care about, there might be some new and interesting things.
Yeah.
So, we want to support patients and the people caring for them and the health plan supporting them use AI responsibly and not to replace clinical judgment, but to enable it.
You said something that I completely agree with. I'll just read it to you. You've called primary care the single most impactful lever to improve population health. I could not agree more. We just had Lisa Rosenbaum, whose whole season is about primary care on the podcast. I think the challenge is we both agree primary care is critically important. Like, oh my, I can't even tell you how important it is. But then at the same time, primary care often has it's the specialty with the most quality metrics or the most stuff to document or the most screenings to do. And I think certainly one of the reasons that primary care is challenging is just there's so much to do and so many kind of masters telling you what you should be doing and how you should be practicing. How do you, like, as a PCP yourself, how do you square those two things that you can maybe both agree with?
So I think one thing that primary care represents is a person or team who feels accountable for your health over time. And to me, that's a principle that is under threat in our current healthcare system. And primary care is one of the primary ways to have that kind of construct in place. And that means that, and that's very aligned with the patient and their family, because you care about your health over time and all the things you want to be able to do in your life and the consequences of poor health. And so we can't lose that, because otherwise we're just completely reactive and narrow in our view and engagement with people clinically. We do ask a lot of primary care. The ownership level of amazing primary care clinicians is just tremendous. They want to be accountable for everything, and then they drown under the burden of it because we don't resource and equip them well enough. And if we just found the way to invest that 10 to 15% of healthcare into primary care that other developed countries do, they would have the team, the resources, the infrastructure. So it's not an individual sport, it's a team sport, but we don't resource the team well enough. If you're working and taking risk in Medicare, you're ending up with an arrangement that gives you 10 to 15% more, to invest into primary care, and you're building a team with smaller panels, more frequent visits, additional skill sets like behavioral health or disease management, nursing support, or pharmacy. You're engaged as people get discharged from the hospital. These are all things that can make a big difference on a panel's health over time. So we have to get out of the world where that burden is an individual burden. It can be streamlined. It should be harmonized. We don't need 100 measures, but it definitely needs to be resourced to the point where it's a team and a system work with great individuals within it.
Yeah, Lisa's quote, I think, is her statistic is I think we spend, primary care is like 35% of visits, but we spend 5%. We invest 5% into primary care. And, if we were to even just make that 10% or 15% for the 35% of visits, we would have a very different looking system.
The evidence is there both in the US and outside the US. It's not controversial, I think, anymore. I could be biased, but the question is, how do we get there and do we commit to it?
I asked a couple independent physicians what I should ask you. One of them asked how you view the reporting requirements or the challenges between large health systems and independent, one or two doctors in an office hanging up a shingle somewhere. The larger health systems probably have an entire division of quality that is reporting all these metrics. How do you think about the scalability challenge of two PCPs and kind of having to compete's not the right word, but having to have the same level of either rigor or reporting as the large system?
My father was an independent one or two doc practitioner.
Yeah, my dad was an independent psychiatrist for 45 years. Yeah.
And the one time I heard him think about quitting is when he had to go onto an EMR. He didn't actually.
Yep, totally.
Then COVID hit, and he definitely didn't want to quit. He
Yep.
he actually kept working even though we wanted him to take a break because he's a pulmonary critical care doc and he was
Oh, wow.
he's already he didn't listen to us, which is great. I think it's a fantastic question, and a subpart under the dialogue around primary care is independent practice.
Yes.
And what does independent practice teach you about clinicians and how they serve patients, and what that can really look like? And I'd say there's a lot of dialogue in the practitioner community, which you probably know well, about what not being independent means for your ability to deliver on what you feel like really makes a difference and keeps you sustainable. I think we have to get to a place where that infrastructure difference doesn't matter. That's not the independent practices problem to solve. It should be the rest of our problems to solve. There's just so much work to actually get to the insight. And I think there's a potential in this digital path where clinical data actually becomes fully interoperable and you can run these kinds of metrics and insights on them, and it's available to people nationally through different means, and it's not a paid good in the some way that only some have and some don't. So totally hear the issue. It's a very real issue. It should not be that way because, again, if we're going to organize the system around outcomes and quality improvement, it means we have to serve everybody.
Yeah.
So there's a need for infrastructure or public funding or making things cheaper through digital means, a combination of things to boost that capacity and deliver those insights for people.
Yeah, as an informaticist, I think about standards a lot. It's like it's embarrassing to admit it, but just like the standards that exist for the internet, the way that you and I are talking across the country to each other in essentially real time, those same levels of like, hey, we're going to agree this is how one computer sends information to another, or one computer opens a web page and how you program it, those same fundamental standards that have unlocked the internet and cell phones and streaming and all these things, I really don't think don't really exist in healthcare.
As an informaticist, you know more than I do. What I'm learning is, you're right, many of those standards exist. We have to get to deciding to require them.
Mm-hmm.
They're used. The data model is the same. The data exchange framework is the same. Where does the complete picture of the patient get created? Where is it held and updated? These are not things that are fully solved yet. They're all technically possible from what I understand. And so, I've been confused and frustrated for 15 years to say, well, why can't I actually see all my patients' data? And then
Yeah.
join these other organizations, we have a ton of analytics, a ton of technology and data. You still don't have the complete picture. Then someone says you're supposed to be able to push a button and get everything through ABC mechanism, and it's still not true. And so that's such a foundational problem, Graham.
Yeah.
I totally agree.
Quick rapid fire questions in our last 2 minutes here. Overhyped, underhyped, value-based care.
Ooh, underhyped.
Love it. Overhyped, underhyped, AI in healthcare.
Ooh, overhyped right now.
Yeah. Most important HEDIS measure that exists.
Ooh, okay. I think there's many important ones. I mean, to me, knowing that we're managing our patients' chronic conditions well, to me, if we could equip people with accurate, timely insights about that, I just think clinicians would soak it up. They'd find a lot of lost opportunities. They'd feel pride in their work, and we'd be able to connect it to avoiding heart attacks, strokes, amputations, hospitalizations. And how great would it be for us to see the impact we have and for others to invest in the care teams and clinical resources and support mechanisms that help people do more of that.
Last one, it's a fill in the blank. You ready?
Okay.
The biggest mistake healthcare quality measurement could make in the next 5 years is?
The biggest mistake would be to continue our path of creating measure sprawl, not driving towards measure cohesion for populations that we want to make an impact for.
Mic drop. Boom. That was amazing. I'm really excited to see what you do as CEO. Congratulations on the new role, and look forward to see what you do to improve quality in the United States.
Thank you, Graham.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.